welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
All right, now we have Trisha Sharma, who is a PGY2 emergency medicine pharmacy resident at Baylor University Medical Center. And today she will be presenting a journal club on Midazolam and Ketamine for convulsive status epilepticus in the out-of-hospital setting.
Hi, everyone. Thank you for that introduction. So like we said, I'm Trisha. I'm here at Baylor University Medical Center, and today we're going to be discussing this article that's looking at midazolam and ketamine for out-of-hospital convulsive status epilepticus. So let's begin by diving into some background. Status epilepticus is defined as a seizure lasting more than 5 minutes or multiple seizures without full recovery of consciousness between these episodes. Status epilepticus can be categorized into two main types. So we have convulsive, otherwise known as tonic-clonic, and non-convulsive, with convulsive being the more clinically recognizable and urgent form. The cellular mechanism behind status epilepticus involves complex disruptions in the balance between excitatory and inhibitory neurotransmission in the brain. Normally, neuronal activity is tightly regulated by a balance between our excitatory or glutamatergic and inhibitory or GABAergic signals. But during status, there's excessive release of glutamate, particularly in areas like the hippocampus and the cortex, leading to activation of our NMDA and AMPA receptors on postsynaptic neurons. This then results in a massive calcium influx through the NMDA receptors that then causes depolarization and triggering a cascade of events that can increase neuronal excitability, causing the neurons to fire in like the synchronized repetitive manner. The biggest consequence of status is cerebral hypoxia, which is why prompt seizure termination is imperative. Benzodiazepines are first-line treatments for termination of status epilepticus. They bind to a specific site on the GABA A receptor, which enhances the effect of our inhibitory neurotransmitter GABA. This binding then increases the frequency of chloride channel opening and hyperpolarizes the neuron. When a neuron is hyperpolarized, it is then even less likely to fire in response to an excitatory input and hence leading to seizure termination. In status, as patients continue seizing, GABA receptors may internalize, leading to reduction in inhibitory transmission and the development of benzodiazepine pharmacoresistance, which can affect up to 40% of patients. Apart from GABA targeting, data suggests that status epilepticus persistence is also related to increased expression of NMDA receptors to the synapse. NMDA receptors are also activated by glutamate and involved in excitatory neurotransmission. So NMDA receptor antagonists, such as ketamine, can help with seizure termination as well. Ketamine is a medication that's found in most emergency departments as well as most EMS crews. Based on this, experts have suggested that ketamine could be considered in the treatment algorithm, but currently there's not a whole lot of data evaluating its efficacy in status epilepticus. Our article today then sought to determine if ketamine, when added to midazolam for treatment of out-of-hospital seizures, is associated with increased cessation of convulsions prior to arrival. Our study is a retrospective cohort study comparing outcomes of all aged patients in a single EMS system. This EMS system was located in Florida and services a population of about 1.5 million people. They transported an average of 230 patients by ground per day. So the study looked at the patients who were specifically transported by the ground for status epilepticus between the years of 2015 and 2024. The study also specifically looked at patients who received midazolam followed by ketamine versus midazolam alone. It's important to note that there was a change in protocol in the middle of this study around June of 2017. So initially, the protocol for treating adults with active seizures was midazolam 2.5 milligrams given intravenously or intraosseously, or 5 milligrams intranasally or intramuscularly. For children with active seizures, the dose of midazolam was 0.1 mg per kg intravenously or intraosseous for a maximum of 2.5 milligrams, or 0.2 milligrams per kilogram intranasally or intramuscularly for a maximum of 5 milligrams. The protocol did allow for a midazolam dose to be repeated once if seizures were persisting after 5 minutes. Starting in June of 2017, that ketamine was officially actually added to the seizure treatment protocol, alongside some dose changes. So after that change, the adult patients with active seizures began to receive midazolam 5 milligrams regardless of route. And for children, the maximum dose of midazolam was increased to 5 milligrams for intravenous or intraosseous routes and remained the same for intranasal and intramuscular routes. After 5 minutes, the doses of midazolam could be repeated once if seizures persisted as well, but if they persisted despite 2 doses of midazolam, the updated protocol recommended 100 milligrams of ketamine in a 50 ml solution of normal saline for adult patients, or just 1 milligram per kilogram intranasally or intramuscularly for pediatric patients. As stated earlier, the study included patients that were transported by ground EMS and specifically, and were given 2 doses of midazolam or at least 1 dose of midazolam followed by ketamine. Patients were defined to have convulsive status epilepticus if they received a second dose of any medication or for convulsive seizures during transport to the hospital. Patients who were pregnant, transported by air, received dextrose for hypoglycemia, or had repeat or incomplete data were excluded from the study. The primary outcome of the study was to assess cessation of convulsions prior to hospital arrival. Secondarily, they looked at the frequency of cardiac arrest and endotracheal intubations after receiving these medications. The study used all eligible patients in their database, so the sample size was not driven by a power calculation. They previously had established that 75% of patients would stop seizing after 2 doses of midazolam, but then hypothesized that the rate would increase to 90% with the addition of ketamine. A multivariable logistic regression was performed to estimate the probability of receiving ketamine for each covariate. And then they used a propensity score model to match demographics, doses of medications, and duration of out-of-hospital care. Given that the efficacy of anti-seizure therapies may differ in children versus adults, they also decided to calculate the unadjusted outcomes for adults and pediatric patients separately. Of 2,610 unique patients who were administered midazolam for active seizures, 688, or about 26%, were included in the analysis. In these, 90 patients were in the ketamine group, which included patients who received 1 to 2 doses of midazolam as well. And of these 90 patients, 85 patients' convulsions stopped. Then there were 598 patients in the midazolam only group, of which 479 patients' convulsions stopped. At baseline, our patients were primarily non-Hispanic Caucasian women between 33 and 36 years old with clinically similar out-of-hospital care durations. Midazolam's initial doses also looked to be administered primarily intranasally, followed by intravenously. They compared the baseline characteristics via absolute standard differences, with low absolute standard difference suggesting that the groups would be very similar. On the left here, we have the unadjusted values, while on the right is after propensity matching. Scores below 0.1 are usually most indicative of very little difference between these groups. So the areas that showed the most variation before propensity matching was that there was slightly more men in the midazolam only group, and that the total dose of midazolam was higher in the midazolam with ketamine group. For our outcomes, 80% of patients in the midazolam only group had resolution of seizures prior to hospital arrival, compared to 94% of patients who got midazolam and ketamine. After propensity matching, these rates were 82% in the midazolam group and remained 94% in the ketamine group. 7 patients, or 1.2% in the midazolam group, were intubated, while only 1 patient, or 1.1%, in the ketamine group was intubated. After propensity matching, the rates of intubation in both of these groups were 1.1%. Also of note, the 1 patient that was intubated in the ketamine group had received a total of 400 milligrams of intramuscular ketamine. In our pediatric population, the rates of secession between groups were 75% in the midazolam group and 77% in the ketamine group. But overall, the study concluded that patients who received ketamine after midazolam did have higher rates of convulsion cessation than those who had received 2 doses of midazolam. So the strengths of the study included that the interventions were well protocolized to where dosing was standardized in our groups. Propensity matching also helped ensure that the patient's baseline characteristics were well balanced. The patient's total out-of-hospital care was pretty similar, so that would have minimized the chance that any patient got extra or less care than the other. And then inclusion of adult and pediatric population casted a wide net in generalization of these results while still analyzing the groups separately to account for any physiologic differences. With the strengths, the study also left a few loose strings. One of our biggest limitations in the study was that the dose of midazolam increased from 2.5 milligrams to 5 milligrams when the ketamine protocol was initiated, which may have contributed to this higher rate of seizure cessation in our ketamine group. The dose of midazolam used overall was lower than what's typically given. Studies have showed that 10 milligrams of midazolam is the recommended intramuscular dose in status epilepticus, while the patients in the study had only gotten 5 milligrams at a time. Furthermore, majority of the patients in the ketamine group received 2 doses of midazolam, and given the similar duration of out-of-hospital care, some of these patients who were supposed to get ketamine were never actually given it because they may have arrived at the hospital before it was able to be administered. Going into the ketamine dosing, the protocolized dose of ketamine for adults was 100 milligrams, while for children it was weight-based, which is not typically how ketamine is dosed. The off-label status dosing for ketamine is 0.5 to 3 milligrams per kilogram, meaning that if we assume that they were doing the lower end of this dose, they are assuming adult weights of about 50 kilograms, which could then lead to over or under dosing of these patients depending on their body weight. Other limitations include that the history of epilepsy was not collected, meaning that some patients may be harder to gain seizure control at baseline compared to others. And then since doses of rescue therapy before EMS arrival was not documented, some patients may have gotten additional benzodiazepine doses or have been seizing longer, which could potentially lead to earlier internalization of our GABA receptors, rendering the midazolam to be less efficacious as well. In these studies, ketamine would have a better role since it targets the NMDA receptors instead of those GABA receptors that may have already internalized. Lastly, given that it was a retrospective review in a single EMS system, larger studies may be needed to validate these results. So takeaways from our study showed that ketamine did lead to a cessation of convulsive status epilepticus. Its role in its treatment algorithms does need further studies to validate these results, but given its efficacy mechanism and ease of use, it is reasonable to give earlier on, especially if patients have been in status for an unknown amount of time or if several doses of benzodiazepines have already been administered. Thank you for attending my presentation, and I will now take any questions from the audience at this time.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.